difficulty now. So let's go back to facts again, talk about what's the the incidence of diabetes in this difficult cohort of patients. So we like our data. This is a pooled analysis of individual patient level data presented in 2018, and if you look at it, nearly about 10,000 patients in both arms, both including PCI and bypass arms, and nearly more than a quarter of patients are diabetic patients. So it's a large representation. So apart from pooled data, you look at these two big trials, which were multivessel coronary disease trial. This is Syntax trial, which randomized patients with multivessel coronary disease to PCI versus bypass. Again, on the left, you can see at least a quarter of patients were diabetic. The second, probably the largest trial of bypass versus PCI in multivessel disease, the best trial. Again, more than a quarter of patients are diabetic. So there's a large representation of patients who have multivessel coronary disease and are diabetics. So, this is a fact, and I think, the evidence supports this particular fact, and it is a need of time, really. So, we look at revascularization outcome, and as an interventional cardiologist, it is not nice for me to present that. Again, this is the data from the same pooled analysis of individual patient-level data, but you see that your Kaplan-Meier curves on the left versus your Kaplan-Meier curves on the right, the patients who are diabetics do worse with revascularization as a longer-term outcome for any variety of MACE outcomes as compared to patients who are not diabetic. So what about drugs? What do we want out of them? And what actually is the evidence of cardiovascular outcomes in the drugs that we use? I mean, over the years, this has been totally the champion of the world, of course, your metformin, and largely we believe the fact that this is one of the drugs which is associated with better longer-term outcomes from cardiovascular side, but actually is not necessarily true though. So the biggest evidence for metformin use was from a very historic trial, your UK PDS trial. And this is, a trial which went on for nearly 17 years and was published in 1998. So very historic data. Okay, fine. We look at the left, and you've got good outcomes that we want to measure, hard outcomes, as we say, fatal MI, stroke, death. And if you look at your forest plots, it's quite nice that the metformin, outcomes are better than the placebo outcomes, but the attention is all in the middle sector, really. And what is that? So in fact, the whole amount of evidence came from people who were overweight out of the UK PDS trial. So there were only 753 patients which were nested within this randomized trial. And in the overweight and obese patients, they were staggering figures, and it looked very attractive, of course. Then metformin reduced his MI by 39%, excellent headline, coronary death by 50%, another amazing headline, and stroke by 41%. And this is a passive follow-up over the next sort of 10 years of the trial. But actually, if you look at it, there were only 39 MIs in this trial, 16 coronary deaths. So these are very, very small numbers. So really, the precision of these efficacy estimates is largely uncertain. And if you look at meta-analysis, of course, this is our highest level of evidence. And this is the meta-analysis from 13 randomized trials, which included metformin use to some degree. And if you look on the right, your forest plot is dead in the center, really. So metformin doesn't necessarily carry the best evidence of cardiovascular outcomes. So I think it would be fair to say that we can be sure that metformin is not worse for cardiovascular outcome, but it's not necessarily the first-line drug in modern times that ought to be sold, thinking that this is going to reduce cardiovascular outcomes for diabetic patients. So sulfonylureas, again, glimepiride was studied against linagliptin head-to-head trial in the Carolina trial. There was no superior efficacy. There was another advanced trial with gliclazide, I think modified release against placebo. Again, there was no superior efficacy as compared to placebo for cardiovascular hard endpoints. If you look at your glitazone's proactive trial, again, failed to achieve the extended primary endpoint. And we like our primary endpoints in cardiovascular medicine because they generally tend to contain your hard endpoints, stroke, MI, death. These are the things which matter. The extended endpoints included amputations, people needing coronary revascularization, etc., and actually there was no difference. But if you look at your 3-point MACE outcomes of stroke, MI, and death, then there was a marginal improvement. But this is with, of course, the jeopardy that there is a 0.4% annual risk, which is increased of heart failure presentations in the patient, which is a contraindication then. Your DPPP4s, there are 4 randomized trials. Again, patients with or high risk of atherosclerotic cardiovascular disease. Again, it had shown no superiority over placebo, and the same data is available for insulin from these 2 larger trials, really, that as an agent, they don't necessarily confirm a better cardiovascular outcome. But there is hope though, and the hope is from 2 newer agents, but not newer to you, but more nearer to us in cardiovascular medicine, because They have both come out quite strong for heart failure data, SGLT2 inhibitors. This is meta-analysis. Again, we love our meta-analysis, and you look at your forest plot in the middle, the meta-analysis from these 5 large randomized trials, they all favor with improved cardiovascular outcomes. And talking about improved cardiovascular outcomes, this is a time-sensitive point to first cardiovascular event of stroke, MI, and death, which are, again, hard endpoints. So second, GLP-1 receptor antagonist. This is data from colleagues in Glasgow. Is an actual powerhouse in metabolic medicine, Naveed Sattar, and another colleague, Matthew Lee. So they put out this meta-analysis. Again, you can see the forest plot in the middle is heavily in favor of use of GLP-1 agonist for improving your hard endpoints of CV death, MI, or stroke with use of GLP-1 agonists. So I think it should be fair to say that this is from the European Society of Cardiology guidelines, and I think Neeta is gone from here, but her comment was quite nice that we need data from different demographics. This is all from European and American population, but either or, these are large clinical trials which have got robust data. But if you look at the algorithm of prescription, then to reduce cardiovascular independent endpoints, which is independent of your glucose control, independent of your HbA1c, then your SGLT2 inhibitors and your GLP receptor agonists carry now the class 1 indication. And following that, if you need additional glucose control, then you should think about choosing drugs who have got suggested cardiovascular benefit, but not necessarily proven cardiovascular benefit, but that will be your metformin and pioglitazone, and this is followed by the rest of your drugs, really. So coming back to our patients, and I'll wrap it up really from there. So our first gentleman, who was a recent coronary presentation, unstable with myocardial infarction, really diffuse coronary disease. Our surgeons weren't necessarily keen to operate because of a very high risk of wound complications and early graft failure. And this is the recent and modern success of coronary intervention, really, that we can treat these patients to very high standards now in intravascular imaging, and the era of good outcomes with drug-eluting stents. So a bunch of stents were thrown into him, treating his LAD, left main stem, his left rim circumflex, and this is a pretty reasonable result that we obtained from his revascularization, and he should do fairly well from the short to medium outcomes at least. Our second patient, a slightly more complicated historic coronary disease patient who got that complicated left circumflex chronic occlusion, and again, this is a success of interventional cardiology now that we are able to treat these patients who got very long history of coronary disease with occlusive coronary disease as well, and this is an area of niche practice for me, chronic occlusion PCIs, and you can see that there's a fair bit of occlusion length over here, but this is what we term it as a dual injection. You can see the retrograde filling into that left circumflex, and after a lot of hard work and working on branches, we are able to open up whole of his left circumflex circulation and reduce his angina, and one would hope to improve his cardiovascular outcomes as well. The last patient that I shared with you, the one with the early graft failure, surgical revascularization, gone through big surgery with a lot of upfront risk, and didn't gain the maximum benefit that we wanted them to gain, although his internal memory graft was patent, but the rest of his coronaries are totally occluded, a proximal right coronary artery which is occluded with a failing vein graft, with a pretty difficult left coronary circulation. But again, with modern interventional techniques, I think we can treat that with very high standards. First of all, we treated his right coronary artery, and this is his left circumflex on the right side. Again, a sort of a setup of chronic occlusion PCI. There is retrograde filling from that vein graft, but we are able to wire this through the opposite side of the coronary to very high standard nowadays. This is rotational atherectomy, all the calcium modification, so we can maximize the expansion of our stents, and again, we got a pretty decent result in regards to his native coronary circulation, both in intermediate to left circumflex, and we'll leave the gentleman fully revascularized again for hopefully future benefit. So final points, I think for me would be that diabetes is a global pandemic, and I think is an extension of thought from last speakers that it is a challenge which is shared in everywhere in the world, really. So diabetes treatment has come a long way to address cardiovascular risks and improve outcome for our patients, and I really do believe that partnership between various disciplines is the need of time. I mean, treating from my point of view as an interventional cardiologist is just not the end of the story, really. Here is where meticulous diabetes control using the drugs which improve cardiovascular outcomes come into play, and really we have to combine the forces together, and it is entirely essential if we are to achieve a linear reduction in adverse events. Thank you very much for your attention. Thank you so much, sir. Thank you. Mike, मुझे तो आ रही है.
हेलो.
मेरा सवाल ये है कि comparing sulfonylureas with placebo, not with any other drug, absolutely no benefit. What is the explanation?
Asking an interventional cardiologist on a diabetes question. so this is trying to trump me really. I was expecting a PCI versus a bypass kind of a question. So, so answer for me will be that as an interventional cardiologist, I look at evidence, and the evidence would suggest advanced trial, there was no benefit. But in modern trials, as an extension of answer, as a modern trials, your SGLT2 inhibitors and GLP receptor antagonists, so there is a comment to be made that large amount of patients were already on pre-diabetic medications, which would include metformin and sulfonylureas. So maybe there is a treatment benefit, and maybe the data is just too long.
Adil, just one point, one or two short questions. What is the cutoff point chronic coronary syndrome for PCI or CABG regarding EF? And what's the recent data about opening of CTOs in these patients? Because there have been some change. And again, there is some, I was in the UK for the ESC, and they said the change in the use of beta blockers after MI, the duration we used to give it lifelong. But I think they have now restricted to 1 year or no. What is the evidence behind that?
So three questions, by sir. First of all is what is the cutoff point for PCI versus bypass in patients who have low ejection fraction? So these are heart failure patients, high-risk patients. They've got complicated coronary disease. Large amount of patients will have diabetes. The answer is that the best data is available from STITCH trial, which is a trial which is from 10 years ago, okay, and carried a slight benefit in regards to mortality for patients over 10 years with surgical revascularization, historic data. Then we came to a modern trial of revived, which we participated into heavily, in fact, and this was PCI versus medical therapy, modern medical therapy of heart failure in patients with LV dysfunction, and there was no benefit of revascularization. So actually, we don't know the answer. So we're about to start a BCIS4, which is a STITCH 2 trial, which will be PCI versus bypass in patients with low EF, and I'm one of the principal investigators for that. So I think that will give us the answer. At the moment this is high-risk group. I think surgeons are generally unkeen to operate on these patients, and I think we can do a pretty fantastic job and probably at better safety margins for these patients. So we tend to incline more so where is an indication to do with PCIs really. So one of the question was about beta blocker, the new evidence about long-term continuation. Again, historic data about beta blockers post-MI, people were started and left on that. But the general benefit in regards to patients who got preserved ejection fraction is minimal to none really. So there are two clinical trials presented recently. Both have shown no superior benefit in carrying on with a beta blocker over and above your usual sort of secondary prevention in patients who have had heart failure. So it is reasonable to stop patients from beta blocker after 1 year if there is an indication to do so. Thank you very much, sir.
Thank you very much. We are highly honored by the presence of our ex-Vice Chancellor, Dr. Alfred Saab. Thank you very much, sir, for your coming here. So due to shortage of time, at 1:15 we will be having lecture from the Dr. Faruqi from Dubai Diabetes Center. So our next presentation is one of the teacher of the teachers, one of the eminent professor, ex-principal Punjab Medical College, Professor Yasin Hashmi sir. Sir, please share. He will be talking on metabolic associated disease. Be seated. There will be a lucky draw for 5 persons for smartwatches. Be seated. जो लोग बाहर भी हैं वो भी अंदर आप पार्टिसिपेट कर लें. देयर विल बी लकी ड्रा.
मैं आपको अपना वो दे दूँ Assalamu alaikum. The chairpersons, ladies and gentlemen, Assalamu alaikum. What I intend to be talking about is the coexistence of type 2 diabetes mellitus and fatty liver, which is not an uncommon coexistence, and how do they implicate so far as the complications are concerned, and what should be our approach while managing them. ये स्लाइड कैसे है भाई? शानी स्लाइड नहीं चलो ठीक है मैं इससे कर लूँ right. This is what I intend to be talking about, a little bit about the nomenclature. More recently there has been some changes in the definition, so that is what I will be talking about, the magnitude of problem. What is the impact of diabetes when it coexists with MASLD, and what is the impact of MASLD when it coexists with type 2 diabetes? And what I will say very briefly about the common biology of metabolic and organ damage. And I think the last two topics partially have been covered by Professor Aadil, and I think a few more speakers in this session are expected to take up the clinical implications of MASLD, type 2 diabetes, coexistence of CVD and CKD, and there is a speaker who is likely to be talking about the selection of anti-diabetic treatment in presence of MASLD. I begin with a case history. As you can see that this is an elderly lady, 70 years old. She is known to have diabetes, hypertension, ischemic heart disease. She has had PCI about a decade plus back, and then cabbage. Uh, so far as her heart is concerned, she is reasonably controlled on medicine. She lands in the emergency room with upper GI bleeding. And at endoscopy, upper GI endoscopy, she is found to have varices requiring band ligation. And you can see rest of the investigations which have been carried out. I'm sure so far as the diagnosis is concerned, nobody has the doubt that the lady is actually having a fatty liver related liver cirrhosis which is decompensated as upper GI bleeding. Now the real questions are, what was the most obvious omission in the management of this lady? And what was the reason? I'm sure the lady had been to the diabetologist and endocrinologist and later to the cardiologist. Her diabetes and hypertension were the main focus of attention earlier on. And thereafter, once she developed ischemic heart disease, 100% attention was given to the management of ischemic heart disease. But at no stage, despite being a very high risk individual for fatty liver, at no stage she was ever investigated for it. And it is only when she decompensated that the underlying liver disease was first diagnosed. It's not very uncommon for people like us to see patients having successful bypass surgeries and other things, only to have upper abdominal pain a few months down the road, and when investigated, found to have a huge hepatoma. I can recall several patients in whom the hepatoma had invaded the vessels and entered even the right atrium. So the reason is, very unfortunately, a fragmented care being offered to the patient. We are a resource-constrained country. People talk about multi